Hello and good evening, everyone, and welcome back to my IVF Fences and welcome to IVF webinars. It's great to be back. And if you've been here already before last year, you know this is our first IVF webinar this year of 2022. And I'm very proud and happy to be back with all of you again. And I do see some familiar names here, so I'm glad that you are able to join us tonight. And as you know, we are here to simply support you. We are here to answer some of your questions. And of course, as you know, our webinars, this webinar is just starting because, as you know, we will be here throughout the whole year, as we just definitely want to help you out with any questions, any advice, or any information that we can provide. And I'm very happy to be back with Dr. Tomáš Frgala. You can see him right here as well. So,
Hello.
Dr. Tomáš, welcome back. You have been with us before. This is not your first webinar with my Evie Advances, and I'm very happy that you are back. I hope you are having a good day and are ready to explore our topic on embryo transfer and how to prepare for embryo transfer. And of course, you have prepared a presentation on that. But I think most of our patients are waiting for a Q&A session. Don't worry, it's going to happen. So of course, remember, you will be able to ask anything that you would like to ask. And I'm sure Dr. Thomas will be happy to help you. How are you feeling tonight? And welcome back. It's been a while. I'm glad you are back. How are you feeling?
Thank you. Thank you. Feeling great. It's getting a little late, but still, plenty of power to go on. That's fine.
I'm
It's
happy to hear
really
that.
nice to see you again. It's really nice to see you. And yeah, I appreciate seeing, well, not seeing, but knowing that you're there, guys. It's very nice to see that you took the time, and we really appreciate it. So, hi, everybody. And I hope we have fun for an hour or so. Yeah.
Thank you so much indeed. So, of course, as you know, we will start with Dr. Frgala's presentation. Let me just mention that he's the head physician at UNICA Clinic, located in Brno in the Czech Republic. And tonight is our first webinar. And Dr. Frgala has prepared a presentation on our topic, but afterwards there will be a Q&A session. So, of course, if you have any questions, you can put those right now during the presentation or even after, of course, and I'm sure he'll be happy to help you out with any questions that you might have. And before we start, let me just mention that my Advifence is a part of European Fertility Society, which was created for the patients because we simply want to educate, we want to advise patients so they can make the best possible and possible decisions. We know that IVF journey is never easy, and therefore we are simply here to help you out as much as we can. And remember that, of course, this is like a Q&A session where you can ask anything you want, but if you want to get like a full-on consultation with all the details, it's always best to get in touch with the physician with the clinic, because of course they always need, I always know it, they always need more details. So don't forget, if you want to ask something, put as many details as you can. That way we can definitely, I'm sure Dr. Fella will be able to help you a little bit more as well. And welcome. Okay, I'm really excited for being able to start this tonight, and I'm sure that you're going to find this useful. Remember, this is going to be recorded, and if you, I hope not, but if you need to leave at any time, you will be able to rewatch this. It will be available on our website, but also on our YouTube channel tomorrow. So that is it from me. Okay, I think we can start with the presentation. Thank you so much,
Okay.
and let's go. Okay.
Yes, thank you for the kind introduction once again. Hello, everybody. I hope you're healthy. I hope you're doing well. And let's get right to it. So the topic is embryo transfer, how to prepare for an embryo transfer to have better chances. We're going to talk about preparation, about the procedure itself, and maybe a little bit about the regimen after transfer. I'm going to mislead you a little bit at the beginning, speaking about the two major characters of the drama. Okay, the sort of leading roles being the endometrium, the uterine lining, in which we place the embryo, and then the embryo itself, where the quality of both plays a definitely important or crucial role in the process. But in due time, we're going to switch the focus a little bit. And of course, we're going to talk about and reveal the true hero of the piece, the patient herself, actually. So we'll try to talk about about, let's say, the holistic approach, or the look at the patient as a whole, at her body and her mind, and what maybe can be done or supported throughout the process to increase the chances or get them to a maximum. So this is kind of one of many possible definitions of the embryo transfer. This one's admittedly is a little dry and a little technical. Insertion of the selected embryo into the uterine cavity. Yes, that is true technically, but what makes it really exciting and kind of stressful is the fact that this is usually the grand finale of the assisted reproduction treatment, be it the stimulation of the patient herself, fertilizing her own eggs with the sperm cells of the partner, and then, of course, the embryo transfer, and then the following care, or be it a cycle where donated eggs are fertilized, and once again, the embryo transferred into the uterus of the patient, the recipient in this case, where we have to prepare the endometrium, the uterine lining, to the best of our knowledge. Or maybe the third category, the frozen embryo transfer of an embryo that was created, so to speak, in one of the previous cycles, and that have been waiting patiently in the cryobank for its chance. So once again, it's the procedure where the physician transfers the embryo into the woman's uterine cavity. Endometrium is not quite, maybe not quite accurate, because yes, the uterine cavity, that title is a little misleading in itself, because the cavity is never opened. It's always filled up with the two layers of endometrium, and we are not placing the embryo directly into the endometrium, but rather very gently and carefully between those two layers of the uterine lining. But I'm quite sure we don't need to talk about that anymore, because I suspect many of you have already been through a transfer and know the procedure. So, condition number one, the endometrium, the lining itself, the bed that we need to make for the embryo, so it would have a good chance to nest, to actually go through the implantation process, grab on, start the communication with the mother's organism, and then eventually develop further and prosper. The endometrium has to have a certain character, certain type, and a certain height. This goes hand in hand with the natural process throughout the natural cycle, when in the first half, throughout the proliferative phase, where usually the dominant follicle grows, provides estrogen hormones, and under the influence of the estrogen hormones, the lining grows. We want it somewhere between 7 and 12 millimeters for the transfer. Anything between 7 and 12 millimeters appears to be sufficient. Anything between 8 and 10 might be labeled perfect, but it's individual. Following the ovulation, usually around the midpoint of the cycle, around day 14, where the ovulation happens. Following the ovulation, the follicle sort of rebuilds, and the cells of the follicle starts to produce a second hormone crucial for the cycle, and that's progesterone. Under the influence of the progesterone, the blood flow in the uterine lining increases. It becomes softer, a little wet, and it becomes actually perfectly ripe and ready for the embryo to nest. While the first phase and the effect of the estrogens, the proliferative phase, actually may vary in length, and we can play with it a little bit. Sometimes it's a little shorter than 14 days. Sometimes it may be a little longer than that. The second phase, the secretory phase, is actually very sensitive to the timing, because following approximately 5 days of progesterone, 120 hours, that's the standard, that's the time when the endometrium is just right, or where the, as we say, the implantation window opens, the time when the lining is perfectly ready for the embryo. There's still discussions going on that whether that implantation window is actually quite short, 24 hours, 36 hours, or whether it's much wider, up to 4 days. We don't know exactly. We don't know what the exact time is. It can also vary from patient to patient, but somewhere around 2 days should be right. We, of course, no matter what the procedure is, and no matter whether we stimulate or just prepare the endometrium, or just actually observe and follow the endometrium in a natural cycle, if it's a frozen embryo transfer, then we can let the cycle run its natural course, as long as the woman does have a regular menstruation. We always check at least once, usually around day 10 to 12, if the endometrium is growing, if it has the right structure, and if it has the right thickness, as we have mentioned a little earlier. Okay, the second condition, or the second, major participant, and seemingly maybe the most important one, the embryo itself and its quality. The embryo develops usually for 5 days in the lab, and throughout this embryogenesis, it should actually divide, then compact, and then eventually develop into the blastocyst stage. There are various blastocyst stages. All of them are fine. Hey, let's move back. That's better. All of them are fine for day 5, be it an early blastocyst, expanded blastocyst, or a hatching blastocyst. We can discuss that actually on the day of the transfer, when we look at the embryos and see the descriptions from the embryology lab. There is still discussion going on which point of the embryo development is perfect for the transfer. Usually it's one of the two options or variants, either the 3rd day of the development or the 5th day of the development, day 3 versus day 5. Nowadays, actually, most clinics veer towards day 5 for the embryo transfer. We do the same thing because we feel that way we can learn the most about the embryo. Until day 3, at least that's what one of the embryological hypotheses says, the embryo develops mainly from whatever the egg brings to the relationship, to the cooperation. From day 4, it's actually the quality of the genome from both gametes, from both sides, that starts to show. Also, that's the phase where many of the embryos stop their development. We feel that if we transfer on day 5, we give a chance to the embryos that are truly viable, that have shown their worth, and that's the time that we pick for transfer and for cryopreservation of the other embryos. This is not to say that day 3 would be wrong, but that's just a preference of the clinic, and day 5 is our preference and has been for quite a long time, actually. There's always an argument saying if you insert the embryo on day 3, you're putting it in the uterine cavity, the best incubator for the embryo there is. However, if you look at it from a different angle, you might say, well, the embryo, while it develops, it's actually moved through the fallopian tube and enters the uterine cavity towards the end of day 4 or at the beginning of day 5, somewhere around that time. So around day 3, it's still in the fallopian tube. It's not in the uterine cavity. But either way, it's fine, and the success rates are comparable. So there's really, no wrong way to do that. Once again, day 5 is our preference. So we talked a little about the endometrium and its importance. The bed has to be nicely made, okay, high enough, soft enough, and with an increased blood flow. We talked about the embryo a little bit, quite briefly, and about the importance of its quality. But I think it's time to focus actually on the patient herself, on the woman who is actually the true hero of the piece, as I mentioned at the beginning. And it's not just the question of the technicalities, the quality of the endometrium or the height of the endometrium, the quality of the embryo, the viability of the embryo, but actually the state of body and mind of the patient. And this is where it gets really tricky, and this is where it gets somewhat difficult sometimes, but also fun, because it's individual. It's different for every patient. Everybody needs something else. Some patients prefer their usual regime. They go to work as if nothing serious was going on, and then just stop by for the transfer and continue, saying, if I focus too much on this, I'm going to go crazy. This did happen to me in the previous cycle. I don't want to think about what's going on right now. I just want to go about my regime and about my life. On the other hand, many patients prefer to actually slow down a little bit, take some time off. We tried to discuss it with them, support them, and offer options actually, which might, point towards or lead them towards the more complete, the holistic approach, such as yoga instructors, acupuncturists, nutrition specialists. There's a psychologist at the ready. Of course, we don't force these on everybody, but these are options that the patient can eventually, choose from, pick from individually, one or the other, or a combination thereof, just to see what works for her best. It's also not just a question of the patient and all of these, members of the support team, but of her family, her friends. Somebody doesn't like to reveal that much to her or to their surroundings. Somebody likes to share. Once again, this is individual. There is no one right way to do that. There is no dictate. There is no procedure that we would force or could force on anybody. We just need to listen. We need to try to adjust and as we go, and we need to actually tailor sort of the approach and the whole preparation on the needs of the specific patient. Of course, her coordinator plays a very important role in that, and her physician as well. One of the most popular actually approaches, as a part of this holistic approach or the methodology, is acupuncture. Once again, there is no right way to do that. I have tried it myself. It was very, very nice. It's always nice, at least for me, when somebody's, taking care of me. And this was very pleasant and relaxing, but there is actually no guideline or no regime that we would dictate or even recommend. If I were to pick, I would probably go for at least one session a week throughout the transfer cycle. The transfer itself usually is timed around day 20, 21 of the cycle. So that gives you 3 weeks, 3 sessions, maybe more. We are also able to provide an acupuncturist on the day of transfer on the clinic. So the patient can have a 20-minute session immediately prior to the transfer, and then once again immediately after the transfer if she wishes to do so. But as I have suggested, it's teamwork, even though that the patient herself plays the major role. She shouldn't feel that all the responsibility is on her shoulders. Okay, everybody plays a role, and ultimately, we always need a little luck. We always need a little help from nature herself. And I just, feel heartbroken when the patients ask me, what have I done wrong? And maybe I shouldn't have done this. I always say, you have done nothing wrong, and maybe nobody else did. Maybe the embryo just wasn't viable enough, or we just were not lucky enough. But if we keep trying, we usually, in a very, very high percentage of patients, persevere and reach the goal. All right, let's go back to the technical a little bit. There are some very interesting technologies as well being used throughout the process. Now we're going, back towards the details a little more. I don't want to go too deep because most of these procedures actually will be discussed in the future webinars and in the future get-togethers here. So please stay in touch with Caroline and follow her program. And I do believe that in the list of topics, I have seen pretty much each and every one of these as a solo lecture or presentation ready. So you will hear eventually about the embryoscope, or the generally the so-called time-lapse technique, where the embryos are cultivated individually in individual wells, and each well has a camera, and that camera takes a picture like every 10 minutes in infrared light, so as to not to disturb the embryo. And these pictures, of course, are lined up in the computer, and the embryologist can actually follow the embryo throughout its whole development, without ever having to manipulate with it, without ever touching it. There's still, I'll be quite frank and open with you, there's still discussions going on at the meetings, okay? The roundtable discussions with the name, the moniker embryoscope or time-lapse technique, the future of embryo selection, or just a luxurious cultivation box. Well, we might not have all the answers just yet, but I always feel, even if it is just a luxurious incubation box, well, let's go for it. The embryo deserves it, and the embryo appreciates it. A very difficult topic, the PGTA, PGTM. I'm sorry about this little switch, this typo. You see mutations happen everywhere. That's the pre-implantation genetic testing for aneuploidies, which was actually earlier called the screening, the genetic screening, and the pre-implantation genetic testing for monogenic diseases, where there's a specific problem that we're looking for. These are also being discussed and being argued about. There are situations where they're very helpful. There are situations where their use might be maybe less important or even questionable. And you should talk to your specialists and, get through the consult. Once again, during these consults, I try to be quite open and true, even if in some cases we just don't know. There is no clear-cut answers yet, but that's a very, very interesting direction. That's still the topic of the roundtable discussions at pretty much every large meeting or congress. Embryo glue for support of the embryo. It's one of the methods that we still collect the data. The studies are still coming in, which are supposed to definitely show whether it has a strong, significant effect on the embryo's chances to nest, or maybe if it's just a marginal method, we'll see. But it looks promising. It definitely doesn't hurt. And just, to get an idea, it's a cultivation medium with growth factors and other goodies for the embryo. The embryo is cultivated for several minutes, like 15, 20 minutes prior to the transfer usually. And then it's taken with this media and transferred like a droplet with microliters of the media into the uterine cavity, thus, getting sort of a snack for the first couple of hours of that nesting procedure. Now, All of that was part of the preparation. If we take a look at the transfer process itself, then these are things that you probably have heard or you know. It's usually recommended, or it's pretty much always recommended whenever the transfer is performed under the control of the ultrasound, to come with a full bladder, because then it's easier to see on the ultrasound. Plus, most women have, if we look from the side, the uterus kind of bent forward in the so-called ante version, and the bladder is right underneath the body of the uterus. To get with the catheter through this curve is not always easy. However, with the full bladder, the body of the uterus gets lifted and the way for the catheter is straight, and then makes it easier. The doctor, point number 2, will insert the embryo into your uterus through a soft-thin catheter. Boom, just like that. It's not actually that easy, but it's not that problematic of a procedure. It's not painful. You don't need to worry about it. Anesthesia is not necessary. We always perform it under the control or under the guidance of the ultrasound, and usually in 2 steps to keep it most comfortable and quick for the embryo. So at first we just take the sheet, the cover of the catheter with a thin probe. The probe is a little more firm and it has a memory effect. So if the uterus is shaped in a, let's say, less than typical way, we can point it in the right direction. Watching it on the ultrasound, we go into the right depth, and when everything is set and perfectly ready, only then we call for the actual soft catheter, and they bring it with the embryo from the lab, and the catheter just slides through that cover into the uterine cavity. So for the embryo itself, the procedure takes just seconds, and it's really comfortable. Some maybe just technical notes that you might hear actually from the team, but I actually get asked about these relatively frequently. One recommendation is, don't use any deodorant, don't use any strong soaps on the day of transfer. And the question is, why is that? It's only because the embryo is brought in an open catheter, and the molecules, of a strong smell, they might be a little aggressive to the embryo. So there should be no smoking prior to the transfer, but also no using of intense perfume. After the transfer, you can do anything you want, and it's not going to have any effect on the embryo anymore. This is only actually a question of the moment where they bring the embryo in the catheter. Okay, how many embryos to transfer? In itself, a whole lecture and a very interesting topic. I'm going to go straight for it. I'm going to say just one. Okay, it's been over pretty much 10 years when even the legislature in the Czech Republic was adjusted to motivate the couples to transfer just one embryo. The procedures, the success rates have been going up, and what used to be a necessity to put more embryos in, to increase, to support the chances, it's just not only not necessary anymore, it actually becomes irresponsible and risky, because a multiple pregnancy carries or represents more risk for the woman, more risk for the babies, which often are born prematurely, and stress for the whole family. So a twin pregnancy should not be the goal of the treatment, specifically not in cycles with egg donation, because the success rates there are around 60%. And if you transfer 2 embryos, you increase your chances only very slightly, but the risk of a multiple pregnancy is significant. It's 45% of couples with 2 embryos used to end up with twins. So it's very rarely done. The couple does have actually the right to decide if 1 or 2 embryos, unless of course there's a contraindication, such as a scar on the uterus following a surgery, for instance C-section, then definitely 1 embryo is recommended. There are exceptions when it's a cycle in a woman over 40. with her own eggs, where the chances are very low, then sometimes, yes, we agree with 2 embryos. In the United States, they still transfer 3 embryos sometimes, just to increase the chances in these specific situations. But generally, 1 embryo per transfer should be the decision, and that's definitely our recommendation. Questions and answers, we'll just really rush through this because there's the true questions lining up already. So we're going to take a look at those and save the time. How long does it take? The actual transfer, as I said, for the embryo, a couple of seconds. For the patient, the physician, a couple of minutes. The complete visit to the clinic, including everything, the preparation, the paperwork, etc., it takes about 30 to 60 minutes, and it doesn't hurt, so no anesthesia or sedation is necessary. Oops, I went one too far. No, this is yes, I did. Sorry. All right, this is pretty much the finale of the presentation. We have talked about these, things, procedures, approaches that might be part of the preparation. There are some things that we have not mentioned, just to keep this fairly short, such as support of the woman's microbiome that can also be, discussed and eventually recommended, either based on the EMA test or just generally to support the microbiome of her intestinal tract or digestive tract, so to speak, or vaginally, or even in the uterus itself. What do we recommend after the transfer? Pretty much normal regime, walks, normal activity. Bed rest is not necessary. It's not forbidden, but there were studies actually showing that the length of bed rest after the transfer does not have any major or any influence at all, actually, on the success rates. So it's not necessary. Normal regime is fine. We do, however, recommend to take it a little easy for the 7 days, for the week after the transfer, and refrain from heavy physical strains. So no heavy lifting, no sports, and maybe no sexual intercourse for about 7 days. But even this is individual, and I'm talking about the sports now. Everybody has their limits set in a different way, and like somebody who exercises a lot, they need their endorphins. They need at least a little bit of power walking or jogging, and that should be fine. I just say, always don't go breaking any personal or Olympic records. Otherwise, a normal regime should be fine. Okay, this is just a conclusion. So yes, we are capable to offer all of these. Okay, the monitoring of the endometrium, the tests if necessary, if there's multiple cycles without any success and you're looking for the possible reasons, the supportive methods, and the monitoring of the embryo quality. But we can talk about that during the consult and set up the combination of these methods so that it fits the needs of the couple or of the patients perfectly. And this is pretty much the last one. So I thank you for your attention and for your patience, and we can take a look at the questions. All right. I'm not sure if Caroline is going to jump in.
Of course, Dr.
Are you going to help me out? Thank you.
Yes, I'm definitely going to help you out. Thank you so much for that brilliant presentation. Lots of information, lots of useful information for sure. And I believe it has been quite interesting for all the patients. And I'm not sure if you can see right now, but there are plenty of questions for you.
Mm-hmm.
So are you ready?
Start at the beginning and just go through those.
I will show you them right here, so don't worry. You will see them right here on the screen, so don't worry. And I guess we can start, okay? Because as I mentioned, plenty of questions. So thank you everyone for sending all the questions already. So here's the first one.
All right.
Let's have a look at this.
Is it better to transfer 1 or 2 frozen embryos, frozen on day 5? We talked about this as a part of the presentation. It depends on what cycle the embryos are coming from. If they have been frozen, as part of the stimulation of a 43-year-old woman, then I wouldn't actually fight her and argue, and I would be comfortable transferring 2 embryos, because the chances in the age group 40 through 45 are actually presented or published as 1 through 3 or 1 through 5%. So that's very low, and it's a good idea to compensate. Otherwise, in all other cycles, younger patient with own stimulation, a cycle with egg donation, I would opt for 1 embryo. But it's always good in these situations to actually discuss and individualize, because the history of the patient is important, previous transfers, a number of previous cycles, actually the quality or the stage of the embryos on day 5. So all of these things can play a role during that decision process, but generally 1 embryo per transfer is the recommendation. Okay, what do I do?
Thanks so much for
Close
the
the
first
question?
question. Yes, there's another one for you right here. So I have read that frozen embryo transfer has higher success rate where down regulation is not part of the protocol.
I
What is
like
your
that.
thoughts on this? Is the age at time of transfer relevant to this? Thanks so much for the question.
I like that question a lot. Okay, there are basically 2 ways how to prepare the endometrium for the transfer in the frozen embryo transfer process. Either we build the endometrium up with pills, with estrogen pills, and then at the right time we step in with the progesterone pills and time the transfer. The advantage is we have it under our control. We can increase the dose. We can prolong the proliferative phase, the initial phase, and play with it a little more. Also, the timing is more flexible. But there's another way, and that's the so-called native cycle, or just to be accurate, the modified native cycle. The truly native cycle is logistically quite straining. You usually have to take blood tests like every day or every other day, follow the dominant follicle very closely, because you don't want to let it rupture unobserved. So usually we modify. That means we start with a natural cycle. We take a look with ultrasound around day 10, 11, 12. And when there's a good dominant follicle of the right size, say 17 through 20 millimeters, and the lining that has the right structure and the right height, we step in. Using an HCG injection, we time the ovulation, so to speak, and then take it from there, build up a protocol from there, usually just applying progesterone for extra support, but even that's not necessary. If the follicle is really nicely grown, it's sufficient, we may just perform a blood test for progesterone on the day of transfer to see if the patient has enough progesterone of her own. The success rates of both of these preparations are comparable, but at our clinic, and not only at our clinic, I have heard these from colleagues from France, Germany, Spain, okay, at the meetings. The success rates with the natural cycle are usually a little higher. The difference is statistically insignificant, so both of them are fine, but we do like the natural cycle. There's one condition: the patient should have a fairly regular cycle, which usually represents a positive or good follicular genesis, reliable follicular genesis. The dominant follicle should be there to provide the hormones for the endometrium to grow. There are now studies in the last half a year or year. There have been actually 3 studies that have shown that the natural cycle, or the native frozen embryo transfer cycle, if you will, or generally a cycle when there is the yellow corpuscle, that means the dominant follicle that ruptures, that there might be leading towards an easier pregnancy, also with lower risks. I'm sure further studies will be needed, but the native frozen embryo transfer cycle is actually quite, quite popular, and it would be my first choice in most of the patients. Let me see if I answered the question. However, higher success rates or down regulation. I see. We actually have used down regulation. Oh, hello, there's a new member to the discussion. Very lovely. We have used down regulation with the GnRH analogs. Okay, it's kind of putting the whole system of the patient to sleep and then starting the preparation. We have been using antagonists, starting the preparation first and then actually blocking the own hormones of the patient. But eventually we have abandoned all of these because they are rather these medications are rather costly. They cost quite a lot of money. And we also have learned and confirmed many times that the regular dose of estrogens that we give in the hormone prepared frozen embryo cycles, and that's 6 milligrams of estradiol per day from day 2 of the cycle, that dose of estrogen in itself usually serves as a down regulation. So we don't really use it. I haven't read any studies, and I cannot comment on whether the success rates with the down regulation would be lower, but I have many other arguments to support actually the simpler approach, the native transfer or the native cycle transfer, or the estrogen prepared cycle without any further preparation or down regulation.
Thanks so much indeed. Okay, Dr. Thomas, it has been a thorough answer for sure. And
Okay.
Karen also would like to say thanks so much. Very
Okay. Good luck.
helpful
Yeah.
teach. Yeah. And actually, as we are on this topic, and I'm sorry about my little friend here, he likes to get
No, that's fine. It's fun.
but I hope that it's okay. However, there is a question similar to the previous one. Why is it recommended to transfer only one embryo? In which case are two embryos transferred instead?
We have touched on that. So very briefly, 2 embryos in older women, maybe over 40 with their own eggs, the chances are lower. You want to compensate. So that's maybe where I would use 2 embryos. Otherwise, the success rates in younger women, they are reaching now. They used to be, 10, 15, 20 years ago, around 10%, then 15%, then 20%. So you wanted to increase your chances. Nowadays, in women up to 35 years of age, with their own stimulation, the success rates are over 50%. You don't really need to compensate putting 2 embryos in. One thing. Another thing, the second one, assisted hatching is often used, actually, where the cover, the zona pellucida, the cover of the embryo is cut with laser, so the embryo has an easier time, hatching, coming out. But in these blastocysts, after they transfer, it can happen, not frequently, that would be too strong a word, but it can happen. We see that a couple of times a year, that the embryo after the transfer can split. So you can transfer 2 embryos and you end up with triplets or quadruplets. You don't want that. And ultimately, the twin pregnancy generally is a lot more strain on the body of the woman. There are higher risks of preeclampsia, diabetes, and other complications, and that's why it's not recommended. The specialists from obstetrics, our colleagues, they always, when we meet, okay, sometimes they're a little mean to us, but sometimes they just say, yeah, we understand, you guys are doing your job. Just let us please ask you one thing. Don't create twins. Don't do that, because the complications that we see here at the obstetrics during the birth, really, they're hard to describe and very hard to digest. So I'm just passing it on. End of quote. Okay.
Sure. Thank you so much for sharing. This is definitely important. Definitely, thank you. Useful. And let's have a look. Next question is right here. What is your opinion about endometrial lining? Should it be tri-laminar before embryo transfer?
Optimally, yes, that's one of the characteristics we're looking for. I have to, be a little more accurate and specific. It should be trilaminar before the ovulation happens or before the progesterone is added to the protocol. Okay. Once the progesterone starts its effect, the blood flow increases and the endometrium automatically becomes, it changes its structure and its look on ultrasound and becomes so-called hyperechogenic, sort of whitish, and the trilaminar structure is actually not to be observed anymore. So throughout the initial phase, the proliferative phase, yes, optimally it should be trilaminar. However, we shouldn't get too fixated on that because the echogeneity is different in all women. Sometimes it's really hard to see. It depends on the machine, on the setup of the ultrasound, on the experience of the physician performing the examination, and even with the studies, it's kind of tricky. You go to a meeting and you listen to the afternoon block, endometrium and its role in, etc., etc. And there's one lecture saying the character of the endometrium, very important. The height, very important. Then there's the next lecture and the next study. The character or the look of the lining, completely unimportant. The height, not important. So we're still getting data. We're still struggling with this, but yes, trilaminar is optimal before the progesterone hits. Okay.
Excellent. Thanks a lot for yet another question and, of course, an excellent answer to this. And a bit of a longer question is right here. What types of tests would you most recommend before the transfer, DNA fragmentation of sperm and karyotyping, or biopsy and immunology test of the uterine when working with egg donation? Is it more important to test the endometrium or the sperm, or in optimum case, would you test both?
Yeah, this sounds like a question from someone who has been through, a couple of cycles without any success. Then we dig deeper. I wouldn't necessarily think about these tests at the very beginning of the treatment, but if there's trouble, if there's poor development of the embryos, the quality of the sperm cell might play a role. If there's early miscarriages, that's the same issue. So that's where the DNA fragmentation exam might give us a certain pointer, okay, what to focus on in the next cycle. Maybe using a MAX method, magnetic activated cell sorting method, for the sperm selection for the fertilization, during which the sperm cells with the DNA fragmentations are removed from the sample. Karyotyping, that would be a big discussion. Not my first choice. Okay, in specific cases where it might be helpful, then maybe yes. The biopsy and immunology tests of the uterine lining of the endometrium, that is actually very informed question. That is a very modern approach. We used to analyze the immunology, the NK cells, specifically natural killer cells, in blood at first. And if they were increased, we actually immunomodulated the patient. We suppressed their immune response. Then the new approach in the past half a year or a year, actually, the time flies, is this other test where we don't measure the NK cells in the bloodstream. No, we measure them in the endometrium itself. So biopsies performed in the immunology tests. If the NK cell levels are clearly elevated, then I would listen to the immunologist if he or she suggested an immunomodulation therapy, okay, be it a corticoid pill as a part of the transfer cycle, be it an intralipid infusion or an immunoglobulin infusion, although those are not very popular because they're extremely expensive. However, we still have to wait and see what the data eventually will show, how truly valuable these tests really are. I have heard, I don't want to bore you with this too much, but I have heard a very interesting presentation from Professor Brosens from Great Britain at the last ESHRE meeting. last year, where in one patient they actually did this immunology test in 4 subsequent cycles, one cycle after another. It just so happened that they did the biopsy 4 times, and in every cycle the NK cell levels were different, thus posing the question, how reliable is this examination really? So we should individualize, and optimally, if there's been a couple of cycles without any success, I would definitely look at both the endometrium and the sperm cells. Both of these are amongst the basics of the preparation and the examination of the couple. Okay.
Understood perfectly. Again, thanks so much. Let's have a look. Another question, follow up, in fact. So would it be worth testing uterine NK cell level if level in blood isn't high?
That's the tricky one. We just talked about this. We don't really know. Okay, there's an immunologist in the Czech Republic, the reproductive immunology specialist, whom I respect and admire very much. She's amazing. She's very well informed. And I did have a chance to talk to her over the phone not long ago. And she published, like a year ago, not even a year ago, an article about the NK cell levels in the blood stream, and actually the immunomodulation and the improved success rates. And when I talked to her after the EFRA meeting, that was like half a year after the publication, she said, "Oh, don't even remind me of that, because I don't even know if that's valuable anymore, if it still carries some value, because now it has all shifted the focus towards the endometrium." I have to say, the NK cell levels in blood, we still measure them, and if they're clearly elevated, we still talk with the immunologist and try to get an advice or recommendation, and maybe use a little immunomodulation if it seems necessary. But the endometrium seems to be more interesting, even though it has its own question marks. And we have to be careful, because there have been many presentations at the latest meetings saying, careful, the NK cells, they have a bad rep. They called the killer cells. So everybody gets, nervous and agitated, but they're actually helpful. They play a certain specific role during the implantation process of the embryo. So you shouldn't just wipe them out completely. You only have to use the immunomodulation where it's really necessary in the patient. And to find out which patient that is, that's really tricky. But yeah, we're trying. We're working on it. We're fighting.
Thank you so much. This is definitely this kind of area where it's still not yes or no answer. So thanks a lot for bringing those questions, for sure. Thank you for your input on that as well. A bit of a longer question now. Let's have a look, okay? So strangely, as I'm told, most women don't have this. I have a lot of feeling inside my uterus, can feel the catheter as it passes through my cervix, and even once it's inside my uterus. This has made IUI and a dummy embryo transfer quite painful. Luckily, the procedure is quick enough for me to be able to tolerate the pain and not need sedation or anything. But does this have any meaning or implications for how things may go? Is it a sign something is wrong and I won't manage a pregnancy if it feels like this?
Well, I think it would require further examination to, answer this perfectly. Ultrasound, maybe hysteroscopy might help, where they dilate the cervix a little bit and insert actually a very thin cable with the camera looking in the uterine cavity to see if there's maybe any atypical shapes. Actually, the dilation of the cervical canal itself might help. It has been written that when the uterus needs to be handled with like extra instruments, pulled, or if it's really painful, that it might react. And that might be, derogatory for the success of the procedure. But usually this isn't a significant difference, and even like a little pain like this or a little unpleasant feelings during the procedure, they don't really like predetermine the patient to a lack of success. So there are some examinations that might be performed to maybe look for the reason or make it a little easier, but like generally this shouldn't really lower the patient's chances significantly. But ask 5 doctors, you're going to get 5 different answers. This is a difficult and quite a wide, actually, discussion topic.
Okay, understood. Of course. Thank you so much for your question. Let's have a look. Okay, Karen has another question for you. Is a blood test to check progesterone level prior to transfer helpful to understand the best implantation window? When should this test take place, and what is the optimum level of progesterone?
Okay. This is a very interesting and a thrilling question. For years, I've been, bothering endocrinologists and specialists at the meetings with the question of what progesterone level is right at what time. Also to add, is the level of progesterone in a different level of the blood? Well, it might be, definitely. And they have been saying, well, no one really knows because you cannot really measure progesterone. Different application routes, injections, suppositories, pills, they may actually be present in the circulation at different forms. Also, throughout the day, progesterone is actually produced in phases, basically. So it depends on when you actually perform the blood test. So for a long time, the mantra was actually, it doesn't make sense to measure progesterone. Nowadays, actually, there are 2 situations where it might be helpful, and that's one, like shortly before, let's say, the oocyte pickup or starting the progesterone in the frozen embryo transfer cycle, you want to see that throughout the first half of the cycle, that preparation, that proliferative phase, that the progesterone level is really low. Then the second time when we like to measure it sometimes is on the day of embryo transfer. There have been some very interesting studies from Spain, from colleagues Bosch and Labarta last year, and they have shown that actually there is a cutoff in the progesterone levels on the day of transfer, that if you don't reach, your chances will drop. However, if you supply more progesterone and you fix that lack of progesterone, you will return the chances actually to the right level. So my answer would be the progesterone doesn't necessarily have to be measured in every cycle, but it might be helpful to measure it like prior to ovulation or the onset of the progesterone generally, and on the day of the transfer. However, I don't think it is very helpful, and it should be used as a ways of timing the implantation window. I think that we're not there yet. Okay, I wouldn't find that very helpful.
All right, thanks so much again for yet another interesting question indeed. And let's have a look, plenty more questions right here. Next one is from Anna. I have done NGS in the past, but am considering a cheaper type of PGS with fresh transfer, but that doesn't check for as many chromosomes abnormalities. Those additional chromosome abnormalities which are checked in NGS, how common are those? Will I cover for the most common chromosome abnormalities with regular PGS?
The most common ones, perhaps, yes, but I'm going to be blunt, and maybe many colleagues, if they hear this, they will argue with me. But I would say NGS, perhaps, although there are very fiery discussions about that, about how reliable the methodology really is. But the older method, and here we're talking probably about the FISH method, okay, where a blastomere was taken from the embryo on day 3 and analyzed until day 5, so a fresh transfer was still possible in the cycle. That methodology has pretty much been abandoned. It has been labeled a historical mistake, and comparisons with NGS have shown that embryos that have been labeled with the fish staining method as pathological had turned out to be actually physiological, have a euploid healthy on day 5. Also, the blastomere biopsy on day 3 lowered in the studies the success rates of the embryos, so I definitely wouldn't recommend that method, and I wouldn't use it. I wouldn't go for the regular PGS as it's labeled here. I hope I understand correctly. I hope I'm talking about the right methods, but I wouldn't go for that, no.
Understood. Thank you so much. If you would like to add anything, Anna, you know what to do. Go ahead, type this in. And let me just go to, again, a question about progesterone, okay? So which is your maximum progesterone level before oocyte pickup to do a fresh transfer? And what is the minimum progesterone level in frozen embryo transfer?
This is a very nice question. Okay, Sebastian goes for the exact numbers. Okay, so before oocyte pickup, it should be lower than 1.5 nanograms per milliliter. The units are important, careful, because there's also nanomoles per liter, and that's like times 3. So here we're going to talk about nanograms per milliliter, which is actually, except in Central Europe, here we always have to recalculate. That's actually the units that are mostly used. So some studies and some sources say lower than 1.5. Some authors, the more strict ones, say the progesterone should be lower than 1 nanogram per milliliter prior to the oocyte pickup. Okay, so pick your source, 1 or 1.5. Okay, 1.5 should be the maximum. Now, the second part of the question, what is the minimum progesterone level in frozen embryo transfer? Here, let's talk about the level on the day of the embryo transfer. In these Spanish studies from Bosch and Labarta, in one study, the cutoff was 8.8 nanograms per milliliter, and in the other study, I think it was 9.2 nanograms per milliliter. So if you want to make it simple, as we do, we use a cutoff of 10 nanograms per milliliter. If on the day of embryo transfer, the progesterone level is 10 or higher nanograms per milliliter, we say that's fine, that's sufficient. If it's lower, we add another form of progesterone. For instance, if the patient is already applying 800 milligrams of progesterone vaginally, one suppository in the morning, one suppository in the evening, 400 milligrams each, then we add an injection of Progedex, a subcutaneous injection, to get the level of progesterone over 10 nanograms per milliliter. So that's my answer. Lower than 1 nanogram per milliliter prior to the pickup, and higher than 10 nanograms per milliliter on the day of transfer.
Okay, perfect. And well, there is again a follow-up on progesterone, so I will go straight to that one, okay? So some clinics check progesterone level repeatedly after the transfer till the HCG testing, and then continuously after positive pregnancy for several weeks. Do you feel this is justified?
That's tough to answer. I mean, on one hand, it never hurts to know. Okay, you want to know as much as possible, but we don't do that, for instance. Okay, we measure it on the day of transfer, and if it's too low, then we compensate and then maybe measure again one more time, okay, a couple of days later, but not on a regular basis. If this should be performed, well, until the HCG testing, that's like 2 weeks after the transfer. That's not that long, actually. So yes, if there's 1 or 2 or 3 blood tests for progesterone, well, why not? But I know that most of our patients, they travel, from abroad a long time. They definitely wouldn't come back to us for that. Sometimes they go to their own gynecologist and they actually ask themselves for this. justified? Well, it's still tricky. There's still the issue of the reliability of the progesterone monitoring. I would say that it's not absolutely necessary, but it doesn't hurt. However, after the HCG testing, I probably wouldn't do it anymore, and I definitely wouldn't do it after week 8 of the pregnancy, because that's where the placenta takes over, and the supplementation of the extra progesterone is questionable, actually. Okay, Caroline, are you still there?
Yes, I'm right here. Sorry,
Yes,
but of course,
that's
don't worry,
fine.
I'm right here. Next question is up. Okay, so if you can explain this one from Karen, I had assumed the thickness of the endometrium lining was the width. Is it actually the height?
Okay, wordplay. What is the width and what is the height? If you take a look at the uterus, like unfast, like from the front, okay, the uterus is like this. It has this pear shape, and the width actually would be like from one corner to the other corner, which is usually 3, 4, 5 centimeters, and the depth is usually somewhere around 5, 6, 7 centimeters. It's only actually when you look at the uterus from the side when it shows you the height of the lining, and I wouldn't call this the width, because I would call it the width when the uterus is like that. If you look at it from the side, I would call it the height of the endometrium, but this is just wordplay. Every gynecologist knows that it depends on how you set the probe, and if you actually, quote unquote, cut the uterus like this in the main axis, then you're kind of looking at it from the side, and it doesn't matter if you call it the height or the width. You're looking at 7, 8, 9 millimeters, and that's what you're evaluating. So it's just wordplay.
Thanks so much indeed for the clarification. Yeah, of course, there's thanks from Karen right here. Okay, another question is up, a bit of a different question we have here. So let's have a look. 39 years old, after miscarriage, week 10, would it be better to stimulate the ovaries in a couple of months and try to get more eggs, or go straight to frozen embryo transfer? Just to.
Okay. This is a very good question. Very good question. It depends on the other circumstances. Either way can have its advantages and disadvantages. If the frozen embryos are of top quality and they have a good chance of nesting, of implantation, then the frozen embryo transfer is not going to set you back, that long. It can be performed in about 2 months' time. So it's not like you're losing years. You're not losing that much of a time with 2 embryos frozen. We might be talking about maybe 6 months. On the other hand, admittedly, we do have patients who, for instance, are nearing the limit of the insurance company, where the insurance still covers at least a part, of the costs. And if that's the case, they don't pay anything. Any insurance company in the Czech Republic, they don't pay anything for the frozen embryo transfer. So in that case, we sometimes keep the embryos, the frozen ones, in the cryobank, and we stimulate again, as long as there's that financial support. One situation. Another situation where maybe there's endometriosis, and there's risks that it might progress and the patient might lose the ovaries, or if there's a really low ovarian reserve, really low AMH, and the risk then in 6-8 months the ovaries won't react anymore. These are situations where it might be a good idea to stimulate again and create more embryos, back up, keep them in the cryobank and save the transfers for later, because the age of the uterus is not that crucial for the success. It's the age of the eggs that actually makes the difference. So this is a very good question, and in certain situations, this might be advisable, yes.
Okay. Thanks so much indeed for yet another question, interesting one, and for sure for your help. Okay, as I mentioned, there are plenty of questions. Let me just mention that we will be slowly finishing, okay? But don't worry, I just want to assure you that if we will not be able to answer all of the questions, we will forward those to Dr. Thomas and his team at UNICA, and I'm sure they will be happy to get back to you via email or any other ways, of course, okay? But we still have time, don't worry. So let's have a look at the next question.
And
Right.
also, just a reminder: I don't know everything, and I don't have all the right answers.
Of course.
And in many cases, there's various ways how to look at the problem.
Exactly.
So yeah, collect the answers, and create your own opinion.
And I know that you definitely need more details in order to properly answer as well, right? Because as much details as you
Exactly.
have.
We need to get to know
Exactly.
each other much better. That's quite right. Yes.
Exactly. So, of course, let's have a look, okay, at this question. So, is it possible the steroids, prednisolone, or hydroxychloroquine, to affect the level of progesterone? What else can influence progesterone level? Is it a good practice to check transfer day the level and additional, maybe injection if low?
Okay. I think we spoke about this already a little, okay, maybe more than a little, about these Spanish studies and the measuring of the level on day of transfer and the addition of the injection. I have to admit, I don't know the answer to the first question. I'm not sure if the steroids, like prednisone, if they affect the levels of progesterone. I don't think so. I don't think that there's a direct cause effect. But what else can influence the progesterone level? The type of progesterone that you're taking, the time of the day, and perhaps other things that I haven't heard about. But I honestly have to say, I don't know. Is it good practice to check on transfer day? Well, that's what we're getting to. It's fairly new. It's been done for about a year now, and it's still not like a recommended part of the procedure. So you wouldn't find it in the guidelines, okay? But I know that more and more clinics do that, actually, following the example of our Spanish colleagues who actually found some really interesting data in their studies. So we don't do it in everybody, but in patients that, in their first transfer, they didn't have success, and we're trying to look for all the details that might influence actually the implantation of the embryo. In the second transfer cycle, we do that. We check it on the day of transfer. So I'm not sure if it's going to be labeled good practice in the future, kind of suggesting that you should do it, but I know it's getting more and more popular. Also, add additional, maybe an injection. Yes, the injection is a good choice actually if the patient is already applying vaginal progesterone. It has been suggested that giving more vaginal progesterone might not be as effective. You might want to add a different form of progesterone. So that injection here, that's a very good suggestion. Yeah.
Excellent. And Melinda, already would like to thank you for your help with that. Okay, let's have a look. A bit of a different question right here. So I have been taking multiple supplements while trying to conceive, such as DHEA, vitamin D, C, E, ubiquinol, NAC, PQQ, fish oil, acai, etc. Is it safe to continue these up to transfer date?
That's a very good question, and honestly, I don't know the answers. I don't think that they would have a negative effect, but I do recommend to my patients, if they take similar vitamins or supplements, to actually stop them the day before transfer. It might be actually the time for them to metabolize might be different, okay, in each one of these. So if you wanted to be like absolutely sure that you're going to be clean of these at the time of the frozen embryo transfer, you might want to stop a couple of days earlier. But honestly, I usually say until transfer, yes. After transfer, no. So I believe that it is safe, but I have no proof. I don't have the data on these. But most of these are supposed to help, and they shouldn't really hurt the embryo. But I don't know. I have to admit, I haven't read any studies specifically on acai or fish oil. Okay. I don't have the data.
Perfect, understandable. Of course, thanks so much still, of course, for yet another question, Karen here. And let me go to the next question, okay? So how many weeks of pregnancy you recommend stopping the progesterone injections while still taking the progesterone vaginal pill 800 milligrams per day? I was told to quit in week 6 of pregnancy, and I wonder if that's why I miscarried.
Well, okay. Yeah, on the last sentence, I kind of have to playfully use that FBI phrase from the TV series. We can neither confirm nor deny that you have miscarried because of this. I don't think that was the reason. No. If you have been applying vaginals, 800 milligrams per day, that's quite a high dose. If the injections had been necessary on top of that, I would actually time the cessation, okay, the stop of these injections based on what the level of progesterone was previously, or why they were actually given at all. But I do believe that week 8 should be definitely safe to stop with these injections. But if they have been added to the protocol just to make sure, and then they were stopped maybe around the time of the HCG test, but you still continued with the vaginals should actually take care of it. So I don't think that was the reason why you miscarried. Well, once again, when to stop? When would you recommend to stop them? That would actually stem from the question, why did I actually start them in the first place? Why did I, give injections on top of 800 milligrams vaginally, which is quite a high dose?
All right. Thank you again for this, of course. Anna would like to thank you for your help as well. And let me see, of course. Right. So, do you recommend PGT-M testing while using egg donor? Is it useful if the sperm has 1% morphology? And if we do DNA fragmentation and karyotyping, does that eliminate the need for PGT-A testing?
That's very interesting. And that's once again, that's quite a grenade. So the first question, my answer would be quite clear. Mind you, you would have different answers from different colleagues. I would say with egg donors, unnecessary. I have seen it in other lectures. I have heard it from my colleagues. I have seen the studies. Yes, on one hand, even in the young woman, 22, 23 years of age, approximately 20% of the eggs are aneuploid, okay, so chromosomally challenged of poor quality. Still, I wouldn't do the testing. The PGT-M testing for monogenic disease would actually be performed only when you're looking for a specific problem. So that would have to be a situation where maybe the gentleman, because the donor has to be clean. She cannot be even a healthy carrier of any mutations. So if in the gentleman there was a problem, the PGT-M might be discussed. But the PGT-A I wouldn't do as the screening test. 1% morphology in the sperm cells. Fragmentation, karyotyping, it does not really eliminate the need for PGT-A unless it shows actually quite a favorable result. Okay, if it's not that bad, then you might say, so we don't really need PGT-A. if it's really bad and there's a risk that the embryos will suffer through that, then maybe you might want to think about PGTA, but I wouldn't rush with that. Once again, maybe a sperm selection method such as MAX might be helpful. If the DNA fragmentation is a little higher, then it helps to eliminate these poor quality or apoptosis pre-programmed sperm cells. That MAX method for the sperm selection. But these are rather complex questions, and we would have to know each other better and talk a little more to get to the core of this, really. Okay.
Of course. Thanks so much indeed. And I would like to just simply mention that if you would like to get in touch with Dr. Tomáš Frgala from UNICA Clinic, of course, there is an option for you. You can go to our website. There is a link. I will send it over in a few minutes as well, and you will be able to get in touch directly with the team. And I'm sure they will be more than happy to give you some more details. And of course, I'm sure they will require more details from you, okay, to get a thorough answer as well. And we have still a few questions left, so let me go straight to this one. I'm 42 and will be transferring own embryos. Are there any negative impact of transferring embryos at different stage of blastocyst development, full blastocyst and an early blastocyst? Or secondly, any negative impact of transferring embryos that were created during two different stimulation cycles?
Yeah, that's a brilliant question, very interesting, and I'm afraid I don't have an easy answer for that. The embryologists, about 10 years ago, they used to say, oh, yeah, if you transfer two embryos, they support each other. Nowadays, it's rather the opposite, actually. Professor Macklin from Great Britain has been working on some very interesting experiments showing that the endometrium actually approaches proactively a healthy embryo. It stays away from an embryo that is not euploid or healthy. But the situation where one of the embryos is a hatching blastocyst and one of them is just an early blastocyst, it doesn't really tell you that one of them is healthy and the other one not. It just tells you that one of them is faster and the other one a little slower, but that's not the ultimate parameter. It's not as if we all went out, ran around the block, and then whoever was the fastest, we would say that's the best human. It just doesn't work like that, and the genetic testing sometimes shows that the fastest embryos, don't necessarily have to be the best ones. So I wouldn't really have a problem transferring these two embryos at the same time. Also, transferring embryos created during two different cycles, as long as the gametes were from the same partners, and if the embryos are of about the same stage, I would be comfortable transferring both at the same time. Maybe, if I may, I would love to share another very interesting study, once again from Spain, a different team though, where they had patients repeatedly unsuccessful that had cryopreserved embryos from different cycles, and some of these embryos were frozen on day 3 and some of them on day 5. Once again, this was a question of the implantation window. What they did was, and what an idea, they actually prepared the endometrium with progesterone for 4 days and then transferred on day 4 both of these embryos at the same time, the day 3 embryo and the day 5 embryo. And they got surprisingly good success rates, and they got multiple cases where actually the patient was carrying twins. So both of the embryos nested, both the 3-day embryo and the 5-day embryo from different cycles on day 4. Okay, so yeah, puts a different perspective on the implantation window once again. And I think that, just judging by this, you can comfortably say it shouldn't really matter that they are from the two different cycles.
All right. Again, Karen, thanks so much. Brilliant question indeed, and interesting case you have just presented to us. So yeah, thanks so much. And of course, Karen, I would like to say thanks as well. Okay. Another interesting question right here. Let me just go. Okay. I'm 48. My endometrium was 5.5 at day 12 and increased to 8 millimeters at day 18, but no layering. Taking 8 milligrams estrogen oral and 2 milligrams vaginal plus sildenafil, 100 milligrams, sorry. Will that impact fetal development if implantation is successful?
Sildenafil, that's going to be something like sildenafil, meaning Viagra for increased blood flow. 8 milligrams estrogen plus 2 vaginal, 10 milligrams total. And the sildenafil or the Viagra, okay. At 48, it can be tricky. 5.5, that's low. 8 millimeters is better. If I wasn't sure about the structure of the endometrium, then maybe I'd draw a blood sample for progesterone, just to see that the progesterone is lower than 1.5 or 1 nanograms per milliliter. And in that case, I wouldn't worry about that layering so much anymore, because what makes us nervous is when the triple line structure is not there anymore. It's hyperechogeneic, which might represent a past ovulation. However, with this dose of estrogen, I wouldn't expect an ovulation. And if the progesterone was low and the endometrium 8 millimeters, I'd say go for it, go for the transfer, because at that age, it's going to be tough to actually get better endometrium and better height. It shouldn't really impact the fetal development, the height specifically in itself. Anything between 7 and 10, okay, should be all right. But it's tougher. It's tougher. The higher the age, the tougher it may be to build up a nice a high endometrium of the right structure. But I would just, once again, I would measure the progesterone. If it was low, then I would go for the transfer.
Perfect. Thanks so much indeed for that again. And possibly that might be our final question for tonight. As I mentioned, don't worry, all the questions that we will not be able to answer right now, we will forward to Thomas, Dr. Thomas, and of course, I'm sure that he will be happy to get back to you. Okay, so let me go to this one. It seems like this kind of topic is very, very interesting for the patients. As you can see, my progesterone level the day before fresh transfer was 290. This 90. Would this impact the implantation of the embryo? How soon should it drop after, and to what level?
Yeah, that's one of the tricky ones. Okay, anything about progesterone, that's a head scratcher always. This admittedly is quite a high level. Now we're dealing with nanomole per liter, and it's almost 300. So as I said, you have to divide by 3 to get nanograms per milliliter. So we're still looking at like 97, 98 nanograms per milliliter, which is quite high. When looking for studies commenting on the progesterone, I have to admit I did find studies that have said it should be at least 8, at least 9, at least 20. If it's over 20, it's better. The results are great. Then I have found a study that said if it's over 20, the success rates drop actually. So it's bad. But this was kind of an exception, an outlier, and I wouldn't really worry about it that much. So I don't think that this should impact the implantation, but I don't know. I don't really have any reliable data. I couldn't find it in the literature. There was just this one study that said if it's higher than 20 nanograms per milliliter, it's bad. But all the others said it's good actually for the implantation. So I don't think it should impact the implantation negatively. How soon should it drop after what? This was before fresh transfer. Okay, so how soon after the transfer? Well, it also depends if you're going to take any progesterone or not. If I had a patient with this level of progesterone, I probably wouldn't add any luteal support. However, here it's the fresh transfer, so it also depends on what kind of protocol it was. Was it a long protocol where everything is downregulated? Was it the antagonistic protocol? Maybe I would just lower the dose of progesterone and check again in, let's say, 3, 4, 5 days. But generally, from what I read, I don't believe that this should have a negative effect.
Excellent. Thank you so much.
Progesterone,
Yeah, lots of questions about that. So definitely an interesting topic for everyone here. And as I mentioned, of course, we see that there are more questions, but as I mentioned, don't worry. I will forward all of those. Okay.
I just
Yeah.
have to say I might not have time in the immediate future to answer all of these by myself and type
Of
these up.
course.
So they might get to the hands of the coordinators. However, they will be discussed with me. I usually dictate the answer and they will respond and send it back. So
And thank you so much
we
for the
will be.
clarification here for that. Yeah, so don't worry. Of course, we are doing our best, but I hope that that was, of course, helpful for you. I do believe so. And well, I would like to thank each and every one of you for joining us tonight, for your amazing questions. This is definitely a very interesting session. And Dr. Thomas, it's always great to have you back. And I'm very, very happy that you were able to join us and you were able to take part in our first webinar this year, because I'm not sure if I've mentioned this, but of course we will be back in 2 weeks' time. Actually, in 2 weeks' time on Tuesday, there is another webinar. There are more webinars coming up. Every Tuesday we will be here. So there are plenty of topics, trust me, and there are very, very interesting topics already. You can always go to our website and sign up. Before we finish, Dr. Thomas, anything you would like to add?
Thank you for the invitation. It was a great pleasure. Thanks for participating, everyone, and thanks for the brilliant questions. Wow, it was a lot of fun. It was a ton of fun. I would like to talk for hours, but we have to get up, early in the morning tomorrow. Anyway,
Exactly.
we might stay in touch. And what Caroline mentioned about these future topics, I have read actually the list of topics for the year, and they're thrilling. Okay, one more interesting than the other, and many of them quite controversial. So I'll be keeping that list. And actually, I might participate every now and then as a listener.
You are
So,
always
great
invited,
job and good luck.
so
Good luck. Stay
thank
healthy,
you so
guys.
much for that comment as well. And well, what can I say? Patients can tell you everything, and I would just simply show you there are plenty of thank yous. So
Okay, thanks, guys.
this is amazing. Thank you so much. And well, as I mentioned, remember it has been recorded. You will have a chance to watch this. It will be available tomorrow on, yes, exactly. It's going to be available on our website, My Avia Fences. It will be there tomorrow. Okay. Tomorrow morning, you will be able to find it on our YouTube channel as well. And as I've mentioned, if you wish to participate in our next webinar, go ahead, sign up. And there are plenty of questions you have, I'm sure, and there are experts there to help you out. Okay, we will be here. Thanks so much. Have a lovely evening, and I will see you in 2 weeks' time. And Dr. Thomas, I will see you soon as well, right?
Good night. Yes, yes, I hope
Perfect.
so.
Thank you so much. Take care, everyone. Good night.
Good night,
Bye.
guys.